Good morning. So, how many of you were totally impressed with my colleague's presentation, Dr. Tom Levy? Was that awesome? Did he give you the data that should persuade anyone that infection is that important and degenerative disease is that important? You know, as a physician, I got prosecuted by the state medical board in the early 1990s for claiming, it was never for what I did with patients, but what I wrote. And I claimed that inflammation was the root of all degenerative diseases. How dare you? That's what they thought. It was 10 years later before JAMA actually published their first article on that. So the real question comes down to, how do we take care of patients if we have a deeper understanding of the pathology, the processes? And I'm going to give you your take-home message now. Right now, it's two things, and that's it, okay? Number one, we die from injuries, and number two, we die from infections. So with regard to injuries, you can also include chemical and toxic metal injuries and so on, but those are the two causes, and that's the take-home message today. We're going to talk about deep blood fungus, dental and other connections to the devastating illnesses, and this, I hope, will be an eye-opener. You know, if you search Dr. Google for deep blood fungus, which happens to be my term, okay, 100% of the time you will find only my reference to it, because nobody else is really on board with this, and yet they should be. In 1891, a dentist, Willoughby Miller, outlined the concept of periodontal disease and systemic illness. He called it the dental cosmos, that the mouth was this microorganism entrance to the body. Current estimates are that about 75% of the North American population has periodontal disease. I personally think that's probably an underestimate. About a third of all Americans skip an annual dental visit, but you know, they don't seem to have any systemic signs of infection, so who cares? Well, the reason to care is because untreated periodontal disease generates a destructive immune response that elevates systemic inflammation. Oh, wait a minute. Inflammation, that's what we've been talking about for the last couple of days. And all of these inflammations and infections are accumulating on biofilms, and indeed the largest areas for your biofilms are your mouth, your lungs, and your gut. About a 45 to 50% increase in the risk for periodontal disease was found in those people with obesity, likely related to the inflammation characteristics of white fat. Now, fatty tissue produces these mediators leading to systemic inflammation, and that also exaggerates the response to periodontal infection. A study based in Sweden showed that young individuals with periodontitis and missing molars were at increased risk for premature death. Oh, wait a minute, you're just missing some molars, and now you've got the periodontitis. Well, neoplasms, diseases of the circulatory and digestive systems, what do they have to do with anything except for the fact that we're talking about inflammatory disease? But not to worry. Of the thousands of species of fungi, only a few can cause a disease or discomfort in people. You go, wait a minute, where'd that slide come from? Because, you know, we think of infection in terms of bacterial. Maybe we could call it viral. But for the most part, we're thinking bacteria. And what I'm going to introduce to you today is a complete revision of that approach. We've got antibiotics for bacterial infections, very few for fungal. And, you know, one of the characteristics in modern medicine is if you don't have a treatment for it, you don't look for it. What you don't look for, you don't find. What you don't find, you don't treat. What you don't treat, don't get better. Well, that kind of condemns our patient population to an endless degree of suffering. But the good news is, according to, you know, the studies, just only a few fungi can create disease problems. And so I'm going to give you an idea about swordfish. You look at a swordfish and you go, that looks dangerous to me. So it would be more obvious that that would be a problem, and indeed, swordfishies can be a problem. You know, if they're sticking through you, that's inconvenient. I would like you to give me a vote. Who do you think won this encounter, the submarine or the swordfish? Yeah, we'll go with the submarine on that one. Now, Here's a sturgeon. Doesn't look so threatening. I mean, it looks like, this is not going to be, we'll call this a fungus then. Did you know that a sturgeon can leap 6 feet out of the water? That means that they can leap into a boat. And indeed, people have been killed by sturgeons, not so obviously nasty. Yeah, that too. You can leave off the T and we've got the same result, okay? But the sturgeons leaping into a boat can be just as deadly as a swordfish. They don't look as ominous. So my question to you, and I'll take this vote, which of these three kingdoms poses the greatest threat to your health? Saudi Arabia, Jordan, or Texas? There you go. So actually, if you scratch off Texas and put fungus, which of these really is the greatest threat to your health? We don't think of it as fungus. I want us to rethink our thinking. There are three great kingdoms. 1, 2, 3. Plant, animal, fungus. Now, the distinction is based on their energy production systems. So a plant takes sunlight, combines it, and makes energy on its own. Now, animals eat plants. Animals eat other animals that ate plants. Fungus eats plants. Fungus eats animals. In other words, the fungal kingdom uses plants and animals as their source of energy. So here's my question. Who's the best, biggest, baddest kingdom of all? Now think of it like this. Plants have to have sunlight and then they get along with any environment. If you don't want them to grow in certain parts of your yard, make sure that you tell them that, and that's where they'll grow. Like in the driveway, right? But the deal is this. If animals and plants get along, that's great. But fungus, if it doesn't outsmart the defense systems that the plants and the animals are putting up, fungus dies. It doesn't have any other options. There's no other choices. It is that most important kingdom. And indeed, the members of the kingdom are yeast and fungus, mold and mildew. They're basically all the same. They have one dictum, and that is survive or die. So if they have to survive or die, compromised patients are their best friend. HIV infection, cancer treatment. I'll say that 3 times, cancer treatment, because what we do is we kill the patient with the treatment more than we do with the cancer. That's just a personal opinion. Corticosteroids, easily available, immunosuppressants, and frequent antibiotics. It distresses me immensely to have patients come in and say, well, I went to the urgent care or whatever, and they gave me what basically is a 4th-generation antibiotic for a super simple infection. Really? And we wonder why antibiotic usage is so out of balance and works so ineffectively in so many ways. Compromised patients also include those with chronic infections. Would that include periodontal disease, nutritional deficiencies, toxic chemicals, toxic metals? Those are the 2 unappreciated environmental poisons that we have. Hormonal imbalances, increasingly a problem because of the other items listed here, and stressful lifestyles. We do have stressful lifestyles. We get up early, we go to bed late, and we design all sorts of demands on our life and our time rather than learning to cope with them well. We are just putting a finger in the dike in our life. We are, for the most part, inadequately managing our days and our nights. And that is what's putting us at real risk for things. Now, fungi can produce 2 kinds of human infections: systemic ones that affect the internal organs, and superficial ones that affect the skin, the nails, and the hair. Now, you might also call superficial infections the ones that affect the oropharyngeal cavity, the sinuses, the lungs, and so on. But, there's kind of a crossover where you're actually talking about deeper organ systems. I think when you're talking sinuses, I think when you're talking lungs, even though they have an immediate connection to the outside. So just think of it that way. Here's something trivial, just a fungal infection on the skin, no big deal. Here's another fungal infection on the skin. That's kind of a ringworm pattern, no big deal. This is more a psoriatic fungal pattern. Here's severe onychomycosis. Now, this is the kind of stuff that we see everywhere in the older populations. You go into the nursing homes, it's unusual to find good-looking nails. Now, you have to realize that that's because the defense system is compromised and is not reaching those areas, is not defending you, and the fungus is getting a toehold. How's that? So the deal is that infection now begins to set the stage for you to be a compromised individual. You can have a vitiligo pattern. No big deal. It's just a skin discoloration, except wait a minute, why are you tolerating that? Here's a sad story I want to tell you. This is just an example of diaper rash. One of my staff members recently has a new grandson. It's a great idea, wonderful thing. Except he develops a rash. So they go to their pediatrician. Now, the pediatrician looks at this. Whoa, the mom had a group B streptococcal infection when the child was born by C-section, so it's not like there was an obvious connection. But the child had tried nursing, and the kid is getting loved and licked on by mama, and so on. So he says they need to go to the emergency room. So they go to the hospital emergency room for a diaper rash. Well, it was kind of flaming and didn't look comfortable. 9 hours later, blood tests, CT scan, lumbar puncture, cultures, oh yeah, and the attempt to get a urine specimen by catheterization, which boogers up poor little kids like that. And you go, okay, and what did they conclude? They concluded that the appropriate treatment was ambulance transfer to Texas Children's Hospital. This is last week I'm talking about. This is not like ancient medicine. It is ancient medicine, but it's being practiced today. All right. They walk in the door at Texas Children's, get shown into a room. The resident comes in, looks and goes, looks like a diaper rash. No shit, Sherlock. So anyway, so the resident goes, gets a senior resident, probably the ID on call for the emergency, walks in and goes, yep, diaper rash. And they get the prescription for nystatin cream, goodbye. Now, mind you, this is about 18 hours after we started with the pediatrician. You know why there's pediatricians is because grandma lives 1,500 miles away. Okay? Grandma would have said, oh, that's a diaper rash, no big deal. This is how we enlarge the incredible, ineffective, costly practice of medicine in our view lately. But what about, let's take some other things. What about knee pain? Now, that's not fungal the way we think of it. What about infections in the base of teeth? That's not fungal the way we think of it. What about periodontal disease? Well, that could have a fungal element, but I doubt it. We should just treat it with antibiotics, right? What if the combination is what you're going to miss and you're going to allow increased growth of the fungal infection? Abscessed teeth, root canals by definition are abscessed teeth. These are the areas where I'm suggesting if we're not thinking fungal, we're not thinking. How about all the other lesions that we get to see inside the mouth, including simple ones like tonsillitis? When I treat patients with infections, what I conclude to be bacterial infections, I am also giving them antifungal medication. Why? Because they have a concomitant fungal infection, by definition. Now, if you don't culture it, you don't find it, right? If you do culture it, you probably don't find it. You have to use Sabarod's agar. This could take weeks before the fungus grows out, and then you're just going to say, well, we couldn't grow enough to identify it. By definition, we have a concomitant infection. So treat them both. And after the antibiotics are done, I still include a few more days of the antifungal medication because you have some residual antibiotic activity that still could stimulate fungal growth. And then, of course, we're into the probiotic, prebiotic return of normal gut function. Boy, that's a big one, too. How about that little infection there? Probably not a big deal. I don't know. It is for that tooth, isn't it? And don't forget the miles and miles of dentin tubules inside that have been impacted by that infection and are transmitting infection to the body. This, of course, means that there will be no more transfer of infection because we have solved that problem. Now we're just poisoning the body with all of that mercury. Beautiful root canals. In fact, nothing wrong with them except for the fact they are highly infected. Now, we think of infected as bacterial, but what I want you to think of is bacteria plus fungus. Because if we completely treat the problem, then we're doing a good job for people. How about post and place those tubes? Well, okay. Except that's a fomite. That's not you now. I think this is a serious problem that we don't recognize when we implant all these joints in people. We've now just put something in that is a surface that is going to happily grow infection. What kind? Well, we're going to look for bacterial and probably not find it because we're pretty convinced in our own minds that it's sterile bacterial-wise. We don't check for fungus. But if you did check for fungus, you couldn't actually demonstrate it because it's hard to identify. What about kids who just have funny-looking tongues or even funnier-looking tongues on adults and such? The oropharyngeal cavity is loaded with places to tuck abscesses, not just bacterial, but also fungal. And remember, if you have fungal growth or overgrowth in the mouth tissues, you're going to have fungal abscesses as well. Now, we'll think of them as bacterial. We'll do IND, we'll do antibiotics, we'll do whatever, and we will miss completely and leave behind the residua of fungal infection, which, of course, poses special challenges to survival. People get fungal infections in the lungs. We hardly ever see them and treat them. Now, it should be easy to treat this. In 1986, I published a book which kind of talked about the yeast syndrome and how basically you could get fixed by doing the proper treatments for yeast, mold, mildew, fungus. It should be easy. Unfortunately, the doctors don't believe it. We suffer because the doctors don't believe it. Now remember, it doesn't matter how smart your doctor is. It matters how good your doctor is. I define good as someone who's able to take care of the problem easily, less complicated, safely as possible. Not just he's able to address your issues and write you prescriptions, which incidentally can be done in under 8 minutes in an office visit. But that's all right. Some of the doctors take 15 to achieve the same inadequate, ineffective treatment program. And we suffer. Now, we can get fungal infections by contact. We can get them from the mouth, from periodontal and other illnesses in the mouth. We get them from the genital organs. That's because everywhere you have a wet surface that converts to a dry surface, like lips and vaginal lips and so on, you have a very tenuous biological area. Here's another tenuous biological area. Hal Huggins, before he died, was doing some interesting thinking about the fact that teeth were different than gums and bone. And here, teeth are sitting in gums and bone. And that he was toying with the possibility that unerupted teeth would actually serve as a nidus in the 40s and 50s to encourage the development of autoimmune disease. I said, Hal, that's a really provocative thought. I wish I were as smart as he were to keep thinking about that, but certainly the infections in the base of the teeth are, I think, very provocative for human illness. How about gut infections? You know, we don't see the gut, and as long as you don't complain about the gut, then we just kind of assume you're okay. What if you're not? And indeed, you know, the biochemical tests are needed to diagnose leaky gut. The biochemical tests are needed to determine whether or not you have, you know, hypochloridria or ineffective pancreatic acids or juices from the liver, the bile, and so on. Sinuses. We had such a lovely demonstration on sinuses yesterday, and the point is very simple. Yes, these areas need to be cleaned out, but what do they irrigate with? Antibacterial. What do they subsequently treat with? Antibacterial. Now, fundamental thing, just to remind you of the original microbiology, antibiotics that suppress the growth of bacteria will tend to increase the growth of other things like fungus. Because the antibacterial antibiotics are not treating fungus, it has no or reduced competitors now, and it can grow and flourish. It just does it in a different way, and we see it less easily. Here's a good example. What about balls in the lungs? You get stuff like that. What's the immediate first concern? Cancer. Now you have cancer. And the question is, what if it's just a fungal ball? Actually, it turns out that if your doctors, rather than just treat, will go in and biopsy, some of these things are clusters of fungus. What a thought. Remember, you can get exposure by breathing things in. People do not get sick because of their DNA. We do not have genetic illnesses as we're kind of told we have. Well, you have to get your genetic SNPs done because that'll tell you what to avoid and things like that. Those are epigenetics issues. In other words, healthy lifestyle is how we stay healthy, and epigenetics are of little interest except in people who have specific symptoms. Let's think of genetics like the library you get from your parents. These are the potential books you could read. Epigenetics are the ones you select to pull off the shelf and read. And if you change your lifestyle, for instance, toward a more Mediterranean diet instead of McDonald's, then you change the books that you read in your genetic library, and that can create dramatically greater health. As Dr. Levy suggested, perhaps that's responsible for the people who do a better job of creating vitamin C inside their system. But what do we do instead? Well, we jam medicines down our throat. A pill is the answer to most problems. Okay? And remember, you don't have to treat the patient, you can treat the paper. All you have to do is get the lab report. In fact, you don't even have to touch the patient anymore. Just get the paper. Just get the report. And that's how a lot of medicine is done, because it's so A to B. You don't have to interspace thinking anywhere in between that. We also get sick, and especially with yeast, because of birth control and other hormones, because they distort the patterns. These are not bioidentical and in natural levels and in natural balances. We also have over-the-counter cortisone now. It's not bad enough that cortisone, a very powerful and very useful drug, it's not bad enough that it's, starting to get available. It's pushed and advertised as readily available. And that creates more skin zone problems because you've now suppressed the appearance of a fungal infection, and therefore it's not likely to get treated, and now you have another entry point for the body. Remember that the basics for healthy living are not the food triangle promoted by the government. Oh boy, I don't know what we're going to do with these people. Maybe ignore them. I would suggest ignoring the government might be much more beneficial for your health. That's what I talked about in 1986. I have not changed my views at all. One of the slogans I have is don't stay sick. D is for dietary changes. O is over-the-counter nutritional support, general vitamins and minerals and stuff. N is for nutritional supplements specific for challenges, and people who get yeast infection have very specific challenges, for instance, magnesium, vitamin B6, essential fatty acids. And then T is treatment with simple antifungal medications. This is for the yeast syndrome. Okay, but we're going to start getting into the little bit deeper stuff here. Mold spores and their mycotoxins enter the body by breathing, by swallowing, and by skin. Mycotoxins. All of a sudden, I'm starting to talk about mold spores and not just simple yeast things associated with bacterial infections and such. And indeed, what I want to talk about is stratification. Stratification is like what you see with the laying down of layers for mountains and such, and you can clearly see that there are distinctive levels and layers You go, wait a minute, so what does that have to do with yeast and mold and fungus and whatever? Well, in my work in the last 3 years, I have seen the yeast syndrome as a superficial layer of illness issues, and a lot of them. I mean, people come in with a whole lot of complaints, and mostly they're related to the yeast syndrome, and if you treat that, a lot of those things just go away and they heal up. But there is a deeper level of illness that we're now beginning to classify as deep blood fungus. Now, again, that's my terminology because you'll see at the end, how do we really define this? Well, what are distressing diseases for deep blood fungus? Rheumatoid arthritis, systemic lupus, ALS, MS, leukemia, leukopenia, all cancers, severe skin disorders, and unexplained immune system disorders, recurrent infection patterns, virtually all other unexplained, puzzling, frustrating diseases. Now, I don't have 1,000 slides to go through, so does that kind of summarize it? So your aunt now came down with the I don't know noma. Okay, I don't noma. I love that term. Guess what she's probably got? Deep blood fungus. Deep blood fungus, because the simple things like a simple yeast infection and stuff that we can come up with and figure out, and mostly that's clinical history. There is an antibody test, but you have to understand how to interpret antibody responses. But deep blood fungus is something which, when treated, can help these conditions. Now, when we're talking about puzzling, devastating diseases that can be helped, why is it doctors say, we don't know how to help you, there's nothing that can help you? They're lying. They're lying because they're ignoring the prospect that infection could be the root of these weird diseases, these puzzling, devastating diseases. The reason that I know they're ignoring that is because my book was written 32 years ago and is still dismissed as just nothing, even though there's about 100 scientific references in it from back then. And it's more true today than it ever was. They're lying. So let's take rheumatoid arthritis and protozoa toxoplasma, elevated antibody levels in RA patients. 42% of patients with autoimmune antibodies display positive IgG titers, compared to 29% of controls. So in other words, it's something a little bit more common in RA patients. Europeans displayed correlations that are as good. What about rheumatoid arthritis and fungi? Now we're talking a little bit different, but high antibody levels to Saccharomyces cerevisiae. That's a common, mold and yeast that we really use. Well, how about 40% in RA patients and 5.3% in NC cell patients, okay? The slightly different group, but elevated levels of IgA against Saccharomyces in patients with rheumatoid arthritis. Simple conclusion, you go, well, that's just because they have a distorted immune system. Or, let's do the chicken and egg thing. Maybe they have a distorted immune system because they have a fungal infection. And indeed, when I treat them like that, guess who gets better? How about coronary artery plaque? Remember I said that you die from two things, injuries and infections. What if what we think of like, a heart attack, and it's neither one of those. What if it's actually an infection that's happening in the heart arteries and leading to a mechanical problem, and we get dead? Well, fungal DNA signatures in heart artery plaques, 92% of samples in 38 cases from coronary atherectomy, where they actually pulled the plaque out. 92% is a little bit high, in my estimation. Unlike Dr. Levy, I don't know math very well, but it seems like a lot to me. And if it's more because we just don't have the technology to easily see it, then it's really more. And what about biofilm in arterial plaque? Most of these images are from the Fry Lab here in Scottsdale because they've been doing really phenomenal work on looking at these deeper involvements. And if you take a look at the biofilm on arterial plaque, they keep finding signatures of eukaryocytes. Now, those aren't bacteria. Those are more advanced organisms like fungus and their brethren. Now, if we can find this there, is it the reason why that is there? Is it the reason why perhaps your body is setting up a defense system trying to isolate that stuff, and now it just mechanically gets in the way of circulation? Populations in carotid plaque. I want you to see at the end here, the last three that are listed right down there are Spumella, Perkinsus, and Ochromonus species. Wait a minute. They're in pretty high concentrations compared to the other things. And remember, this is plaque taken out of carotid arteries. And, they're looking for bacterial involvement and so on. And what they're finding is these, not prokaryocytes, but eukaryocytes, more advanced organisms along the lines of parasites and fungus. Now, what are the most common eukaryotes in chronically ill patients? Number one, if you remember nothing else, remember Phenoliformis. It has a great name, Phenoliformis mosii. It is a fungus that infects in the roots of various plants. It is the most prominent one we find, which would suggest somehow it has figured how to get inside us and survive. Then Perkinsus species, these come from oysters. Saccharomyces, this is from a variety of food sources and such. The most common ones include Hydrurus and Spumella and Saccharomyces, Toxoplasma gondii, but the number one is the Phenoliformis. This thing literally lives inside the cells of the roots of these plants. And why does it do that? Because it increases their hydration. You get bigger, better plants. It also seems to grab hold of toxic metals and keep them from affecting the plant. So there is a positive benefit of that sitting out there in the plant kingdom. There's not such a positive benefit in the animal kingdom. That would be us. Now, here's the glitch in the system. What is that doing inside us? How is that doing inside us? Is it a marker or is it a major player creating illness for us? It was described in 2010 as a specific genus because we're starting to get genetics that can identify this thing. It was originally found 50 years ago, 1968. Perkinsus species comes from oysters and other mollusks. These are nasty little bastards. Hydrus fatinus, yeah. These are from streams, okay, and they're kind of like algae patterns. Spumella is, these are very organized little early plant systems, okay? And Saccharomyces used in winemaking, baking, brewing, and so on. Well, here's the problem, okay? We are faced with things like these infections and then toxoplasma that Dr. Levy talked about as well. These things are all around us in our environment. So the question is, why do we get tagged with them? Well, that's really the big question, and that's what I'm spending a lot of time looking at. Dr. Fry has just released a published report on chronic fatigue syndrome. How many people know somebody with chronic fatigue? Oh, come on, raise your hands. You've got family members, I know that. And how come they don't get better? Because we don't know how to treat it. Why do we not know how to treat it? Because we don't know what causes it. And if you don't know what causes it, you don't know how to treat it, therefore the patient doesn't get better. And every one of the patients showed Phenoliformis in that study. Everyone. And you go, wait a minute. Chronic fatigue syndrome could be a fungus? Yeah, a deep blood fungus, not just a simple casual one. How about osteomyelitis showing, again, fungal patterns? Wait a minute, osteoarthritis, isn't that from overuse? Well, what about if your body can heal itself and adapt to overuse quite readily? As a matter of fact, a lot of people who come in with osteoarthritis have it in one knee, not the other. What's the distinction? I think it's because they've injured that knee in such a way the defense system and the repair systems can't work as well. They didn't hop around on one leg and overuse that one. They have something different about that leg. Rheumatoid arthritis and fungi. High levels of, as we talked about, anti-Saccharomyces. These are real live lab tests, folks. These are not just looking at rheumatoid tests, they're looking at infection markers. Chronic fatigue syndrome, microbial DNA, the discovery of Perkinsus is particularly intriguing. Remember, Perkinsus is related to oysters and other mollusks that we eat. But the most frequently detected one is phenoliformis, detected in 78% of the samples that this particular report was several years ago. Next-gen testing is what it's called. It's sequential DNA testing. It holds the promise that infectious disease will be something we can understand because we can actually take snippets. Oh, guess where they're from? Your circulating blood. They're drawing blood samples and running them through genetic testing and finding markers for specific fungal and other eukaryotic infections. In other words, we're able to document that your bloodstream is showing fungal and other infections. Now, of course, the way we're taught in school is that you can't have circulating bacteria or fungus or whatever, because that's called septicemia, and you're going to die. So if you can't have it, and that's where we find it, maybe we're going to have to rethink things, that chronic disease might be a smoldering control of a fungal or similar infection in your blood because it's from other tissues, and that you finally succumb to that illness. And we call it that illness. We never look for an infectious disease cause for it, a deep blood fungus. The chronic fatigue patient here, I circled in red on the bottom, the potentially novel part. What they're doing is taking a genetic SNP, and then comparing it to the National Library of Medicine. They have this big, genetics library, and they go, oh, well, this is about 70% of the time. This one looks just like phenoliformis, but 26% of it is not quite a good match. I think we're looking at evolution in progress. These things are making slight changes, and this one just happens to be more advanced than some of the others. It's very common to see 98, 99% of the genetics are tagged there. So, a common finding in the blood of chronically ill patients tested in the Fry laboratory. It is a plant symbiote. It works great for the plants. It does not work great for us. And the bad news is it has a huge genetic mass, and it shows significant genetic diversity. In other words, this puppy can evolve. This puppy can change in regard to its environment. So as we make mistakes in taking care of patients, we might be actually creating the next generation fungus. This fungus was the only microbe detected in all 3 cases of coronary plaque, a common finding in chronic fatigue syndrome and in some normal control patients. Okay, normal control patients showing positive findings. Who threw that little hook into the story there, okay? That's a red herring, because are those patients getting sick and we just don't see it yet? Are those patients going to exhibit signs and symptoms of illness at some future point? Are those patients actually well along the way, or maybe just a little bit along the way in terms of losing their immune system control over a fungal infection? We don't know. Those are the intriguing and fun questions, because right now what we have is a qualitative test. Yes, we find it, or no, we don't. Yes or no. We don't have a quantitative test where we find a whole bunch of it, and then if we do treatment and we see it go down, all right, the quantitative test tells us that that treatment is winning. We don't have that yet. Okay, we don't have that. We still have qualitative. But what's a qualitative test in normal patients? In my worldview, those patients should have their, how about vitamin C levels increased? How about looking at the other items in their nutritional background and taking care of that? So, next generation sequencing has the potential to solve the mystery of chronic disease, especially inflammatory disease. Because remember, ultimately, all of these diseases are inflammatory diseases to some extent or another. Infection, by definition, is inflammation. Inflammation, by definition, is immunity. And I look at, when patients come in, I see those 3 things as exactly the same. If I have inflammation, I'm looking for the infection. If I have immune problems, I'm looking for the inflammation and the infection. They're all the same. It's just the same ball of wax looked at from different angles. And when you look at it that way, you actually can treat patients very effectively. We've got a constellation of bacteria, fungi, protozoa, and algae that are attacking us. And now we can actually use a laboratory test to see it. We're talking cardiovascular disease, chronic fatigue syndrome, fibromyalgia, no longer funky, weird, I don't know how to treat you, we'll have to do a zillion different things. Let's treat it as fungus. Osteoarthritis, autoimmune disease, gastritis. You know, these people who go for 20 years, my gut has never been good. I have gut problems. I was just born that way, whatever the excuse is. Interstitial cystitis. You know, for years we've known that interstitial cystitis is an infection pattern, an inflammation pattern, an immune system pattern, and guess what? It can respond very nicely to antifungal treatment. The use of this sequencing in far more difficult and chronic cases might really allow clinical improvement. All right, well, let's talk about biofilms. Years ago, we had a wonderful whole day on biofilms at this meeting. And what we found was that, you know, biofilms are the explanation for people getting sick. Bad biofilms get sick people, and good biofilms get healthy people. And the contribution is the fact that these biofilms can harbor good or bad populations, not just of bacteria, but of viruses, fungi, protozoa, algae, fungus, and so on. In blood samples from the patients with lupus, the DNA stains and cultures revealed an unknown protozoan exhibiting a profound biofilm-forming capability, and it was called Protomyxoa rheumatica. Big mistake. It wasn't. Okay, but we were looking at it in a biofilm. This was Dr. Fry's work about 10 years ago. Looking at it in a biofilm and struggled, and finally were able to show some organisms of it, called it a bacterium. And when you are able to get genetic testing on it, it's Vanilliformis mosei. It's a fungus. But don't blame Dr. Fry, because PCP pneumonia, pneumocystis carinii pneumonia, which is common in AIDS patients, for years was treated as a bacterium. Guess what's a fungus? So now that we're getting deeper probes into the nucleic acids, we can actually look at what these things are, which gives us the opportunity to actually do some treatments. There's biological confusions, and with Vanilliformis mosei, it's starting to show us new worlds and vistas. Valley fever was thought to be a coccidia protozoan. It's fungal. Pneumocystis PCP pneumonia is fungal. So here's the new diagnostic approach. The biofilm matrix gives us significant hurdles for treatment until we really assess what's going on in the biofilm. In other words, when we really appreciate it's not just a collection of bacterial, that's not what your periodontitis is. It is bacterial, fungal, protozoal, algae, and so on. Now we're starting to take a look at how the community of organisms makes us sick. DNA, eukaryotic DNA, not ours, but fungal and similar protozoan, MS patients, ALS patients, that DNA is in their biofilm. Is that the cause of their treatment, or because of their illness, are they now susceptible to the problem? And that's what they're showing us. How about carotid angioplasty? You know, they go in and they scrape out the carotid plaque that's blocking dense DNA staining material. In other words, it's not just a little bit infected, it's definitely infected. Chronic fatigue syndrome appears to have this infectious component, but we don't know if it's direct activity from the infection or it's immunologic failure, which then allows the Vanilliformis to show more profound effects. We don't know, but we can tell you that polymicrobial infections in the oral flora accelerate inflammatory atherosclerosis. In other words, if you have periodontal disease, and dentists have known this for years, you have accelerated problems with your heart. You're going to show more and advanced and earlier heart blockage disease and other areas in your body as well. Invasion by microbes appears to favor other host challenges that influence plaque formation, such as altered lipid profile in the host. There's all this thing about, oh, we've got to give you statins and we've got to slam things around. Actually, what we have to do is treat the cause of what your body is doing to try and alter its blood fats. I'll give you an example. LDL cholesterol, which is what they want to slam down with statins, okay? Originally, they wanted to get it below 100. Now they're looking at below 75. But LDL is what's necessary for LP little a. LP little a is what you use when you don't have enough. Are you ready? Vitamin C. Vitamin C is the protectant to your endothelial linings, your blood vessel linings. And when you don't have enough vitamin C, you compensate for it by raising your cholesterol levels to get more LP little a, which will go in kind of like a flex seal and help protect those arteries from getting atheroma or blockage disease. See, the story starts to kind of knit itself together. So statins modify cardiovascular risk, maybe by antimicrobial activity. It turns out that statins are antifungal. Whoa. Statins? Antifungal? Yeah, and the more effective the statin, the more better that it lowers your total cholesterols, the more effective it is as an antifungal drug. So it might be that the actual improvement that is claimed with statins, and there's a lot of issues with that, but that actual improvement may be because it's controlling deep blood fungus, or at least forestalling the effects showing. How about MS patients? Intravascular abnormalities. How many people know about these abnormalities in MS? In Italy, they learned that they could take a catheter, like you do for balloon angioplasty, and run it up to the base of the brain through the veins and blow up this gummy substance that they ran into, and then deflate the balloon and come out. And MS patients could show improvement from weeks to months and then needed to have it repeated. Now, it's a very dangerous procedure. There's less than half a dozen centers in the United States that will continue to do that. But wait a minute. Well, let's go back for a second. What is the gummy material? What's the gummy material? I personally think that's the biofilm. And that biofilm just mechanically in that area can readily grow and obstruct brain drainage, okay, blood vessel drainage. And indeed, if we treat those patients for deep blood fungus, we should expect to see improvements and not have to worry about doing the mechanical treatment. Phenoliformis mosei is among the most ecologically and economically important species in that group. It's natural in a wide range of habitats and climates. Does this sound like we're not able to escape this one? It has among the largest mitochondrial DNAs in the fungal kingdom, and it is really very adaptable. All right, microbes in treatments. Although there might be an absence of a clear mechanism of action, when we do treatment for SLE, lupus, okay, chloroquine, hydrochloride, an anti-malarial drug, other anti-malarial treatments like quinine derivatives, doxycycline, minocycline, been shown to be effective in MS. But, MS is just a neurologic disease. What are we doing using these anti-eukaryotic drugs? Well, because I think what we're dealing with is fungal and other protozoal infections. Antimicrobial therapies are not curative in these diseases. It may be that we're slowing the progressive and that these diseases will continue to progress but at a different rate, but I'm going to address that at the end of the talk. The dysfunction in the immune system in the patient might be the most important thing because we don't understand whether we're dealing with the chicken or the egg. We're definitely seeing phenoliformis and other eukaryocytes in the DNA sampling from the bloodstream, so we know it's in there. But the question is, why and how much is its contribution? So when you take into account all these findings, it looks like a definitely multifactorial process. It's unrecognized polymicrobial. You do the culture and you want to see what does the culture show? Well, it showed this one, okay? But that's just one of the very many likely present, and we have to understand clinical laboratory limitations in terms of identifying bacterial and other infections. I was a lab technologist before I went to medical school, and I'll tell you, it's a struggle in the Bacti lab to get some of these things to grow up and show what you really want to see. You might not get enough of it. But now we know that we've got targeted protozoa in atherosclerosis. In other words, heart disease, which is the number one killer. Previous reports had just indicated aberrant eukaryocytic cells. No, they're probably the primary ones. A complex biofilm community having bacteria and protozoa in the developing arteriosclerotic plaque. Now, these results may be consistent with a complex community of bacteria and protozoa that are developing, oh, wait a minute, excuse me, these are from root canals. Blanche Gruby provided these as their primary ones that they're seeing. Does it look to you like there's a whole range of bacteria that we're looking at, and they have not really yet tooled up to start looking for fungus, but that's coming. Fungus, protozoa, these things are what are killing us. Remember what I said, we die from two things, injuries and infections. And I'm dealing with the infection one now. And the infections create injuries inside, like atherosclerotic plaque that blocks your heart, blood flow. That's an injury, but that's due to the infection. So we propose the following scenario here: polymicrobial biofilm infections. The initial insult, you get, something going and it incubates, and then in the majority of individuals, they kind of keep things under control, which is why we survive long enough to raise kids and then vote right or wrong and whatever. But it may be that, these bastards are protected from the immune and inflammatory responses by a whole variety of chemicals floating around, probably pro-inflammatory ones. And that's what allows that biofilm scaffold to become so effective. In periods of emotional stress, illness, trauma, dietary excess, these communities may resurge, create problems, and that's significant because cracks in the biofilm could also expose these organisms to the immune system and might be part of what seems to be an immune system response against these things. So in other words, we're still back to the chicken and the egg thing, but it may explain the relapsing and remitting nature of multiple sclerosis. Maybe it's just the infection waxing and waning, or our response to it. Now, it's well known that biofilm-dwelling bacteria play a significant role in human disease. We know that already. But protozoal infections may be at the heart of a variety of these chronic human diseases, the puzzling, devastating, unusual ones. And, we're also talking about aquatic-based protozoa, in other words, one from the water supply and such. Now, the Fry Lab and others have said they hypothesize that these protozoa may represent a non-trivial component in human disease, and the human vascular system may be where they actually colonize, which is why we would then see blockage disease coming, and that is a previously unrecognized vascular polymicrobial biofilm phenomenon. In other words, wait a minute, biofilm inside the arteries? Well, yeah, that could be, because that would explain why we're seeing these DNA samples and the plaques and such that are being removed at surgery. That could either trigger or potentiate or contribute to vascular and immunological dysfunction. And remember who we're talking about. We're talking about vascular and immunological dysfunction in patients who are vitamin C deficient. Why can we make that claim? Because we're all vitamin C deficient. So in other words, we lack some of the things that would otherwise help to protect us. Now, prokaryocytes are not consistently observed in atheroma debris or filter samples, but you can detect these in filters that, vascular filters that are removed by people. And wait a minute, that suggests they may be playing a role we don't really understand. And again, we're talking about the inflammation process, and molecular studies have shown that periodontal disease, remember we talked about one of the early routes of ingestion here, and the associated bacteria and dental plaque have now been linked to arterial disease in addition to the understanding of chlamydia, which was 40 years ago. Protozoa include hundreds of thousands of diverse organisms, hundreds of thousands, and many of these play critical roles in cardiac and blood-borne diseases. Fungi have been previously detected in our atherosclerotic plaque and may actually be major players we just haven't appreciated. How about 26% of the blood samples showed prokaryotic traces, but but 100% of the filter samples did. And you start saying, wait a minute, that means that we're just missing it a lot of the time. Yes, and this is what I love about doctors. Well, the test didn't show it. Oh, okay. I'm hoping you got the right test and the right lab did it and you understand how to interpret it, because the test didn't show it doesn't mean much if the patient dies because they don't get the proper treatment. It doesn't mean much. So, let's see. Here's one that was previously unreported. P. guagwati, a known metazoan. That's a very expensive protozoan. This organism, like others, have not been previously reported detected in human samples. It's an interesting observation now that we're seeing these things by DNA sequencing. So involvement of the eukaryotic organisms in the cardiovascular system is now really just at the beginning. You're going to see more and more understanding of this if you look for it. So fungal, nematode, cestode, trematode, those are worm infections, also known to be responsible for myocarditis, that's heart muscle inflammation, and vasculitis, that's blood vessel inflammation. In other words, how we get sick in our heart and blood vessel system. Inflammation plays a central role, and that raised the possibility that infections may trigger or be the source of chronic inflammation, or certainly are worsening it when it's present. These organisms may be responsible for atherosclerosis. They are enriched in atherosclerotic plaque. They are not found just in the peripheral blood. They are located, concentrated in the arterial walls. Here's a leukemia patient. Pat comes in. She has chronic neutrophilic leukemia, greater than 50,000 white cells. Now, interestingly enough, she was completely normal until they were working on a house. This is over in Europe. And they were tearing out interior walls and everything. Well, you know, older houses in Europe could be made of stone, and stone doesn't breathe, and indeed, it just weeps in the humidity and stuff. And the workman called her over and said, hey, look at this. It was solid fungal growth on the inside of the stone walls when they got the wall boards off. She wasn't sick until just after that. Fascinating, okay? Who would think that doing your house would get you in trouble? We did antifungal, antiparasitic treatment on her, reduced her counts to 19,000. She's had a lifelong history of hives. I think of hives as a chronic activation of your complement system, the very primitive part of your immune system. She had thyroid goiter and rheumatoid factor and such. These are interesting in patients that we don't have good explanations for, like leukemia. How about Sissy with skin lesions? Her horses developed lesions than she did. Dermatologists were stumped. The animal pathologists were uninterested. One of the horses died. Now that should get your attention right off. Wait a minute. She and the horses look like they have the same kind of illness issue going on. One of them died. Well, it's taken us literally years, and she is almost completely better. It is fantastic to see what nobody else was fixing. How about Cindy? She came back from the Middle East and developed the severe dermatitis, and indeed, she was accused of picking her skin off as these lesions and was diagnosed as severe delusional parasitosis at the best clinics in the country. Well, you know, remember what I said. If you don't diagnose it, you don't treat it. You don't treat it, it don't get better. So we treated her antifungal, antiparasitic, and she got dramatically better. She's all done. Bile duct cancer patient, Glenda, she was proposed for chemotherapy, severely symptomatic. I mean, literally, they told her, you are dying. And she came in. We have a lot of questions we ask when someone comes in, and she was all 8s, 9s, and 10s on all her symptoms. And within 6 weeks, she was 2s and 3s, or 1s, or 0s with antifungal treatment. She has maintained her improvements over a year and a half. Prostate patient, Jim, prostate biopsy, high-grade intraepithelial cancer, PSA level 8.6, and then all the way down to 8, and it just lingers there, and the urologists say, well, we don't find any evidence of cancer. Indeed, his PCA3 test was normal 5 years ago. How about altered immunity patient, Kelso, chronic neutropenia, white cell count of 1.5 to 3 on a good day. Lymphopenia, basophilia. You know, she's got lead shot in her left thigh. Well, you know, things happen. And she had a remote history of lichen planus, which we fixed years ago. But the thing is that she's maintaining an intense